Welcome to the Pharmacy Inspection Podcast, where we discuss topics related to sterile and non-sterile compounding pharmacy in an effort to promote compliance and increase quality. The Pharmacy Inspection Podcast is a member of the Pharmacy Podcast Network, delivering quality and meaningful conversations and discussions about our pharmacy industry and the critical role pharmacists play in our healthcare systems. Learn more at pharmacypodcast.com. Please welcome your hosts, Brian Prince and Seth DePasquale.
Hello, compounding pharmacy friends and colleagues. Thanks for joining us for another episode of the Pharmacy Inspection Podcast. Today, we have part 2 of our conversation with Bill Fixler. Honestly, his first podcast is still one of our most popular to date because really he's a wealth of knowledge. This next part of the conversation will not disappoint. This is another one where you might want to take some mental or actual notes. Let's pick up where we left off, talking about 503As and having a pharmacy manager also playing the dual role of the quality assurance manager.
So, yeah, it's interesting. You know, in the 503A world, like you're saying, you will see a lot of managers or PICs or even, owners who are also PICs in that role of quality assurance. And you're right, when you think about it from that standpoint of, it really needs to be somebody that is pulled out of the situation, not in it on a daily basis, and literally just comes in to look at it from a quality standpoint, and that's it. There's no real biased in that. It's a great way to set things up. What do you think if you had somebody come to you for advice because they wanted to start up a 503B, or maybe they wanted to transition their 503A to a 503B? What's some advice that you kind of wish you got before undertaking all your 503B projects?
I think hands down, doing a 503B as a startup, doing a transition from a 503A to a 503B is extremely difficult. If you think you can do it in 2 weeks or even in 2 or 3 months, again, learning from quality, trying to make sure everything's go right, it's not going to happen.
So why is it easier to do it from a startup point of view rather than transition?
There's when the law came out in 2013, I think one of the ideas was the SPO, which is standard product labeling. Everything's put into a standard format that gets uploaded into the FDA's website or FDA's computer database. That's for all powder companies, all manufacturers, if you're a repackager, labeling. So they basically see everything that's on the U.S. market. You can be anywhere in the world, you can have an access, and you would upload. One of the things that was required when you start was in your initial registration, you were to basically upload any compounding you had done in the previous 6 months. I ran into these issues, and I talked to the lieutenant commander in this area of the SPL formatting. And the FDA database website is designed for big pharma, is designed for powder companies. It was never really set for pharmacies. They've been working at it, but one of our issues was obviously you don't upload everything you made for a dog and a cat. But let's say you've got 3 docs down the street and they write for hormone replacement. You might have a bias 1.5, then a bias 2.5, then a bias 3. And each one of those might have 4 different types of testosterone added to it. You could see that, yes, you're working with maybe 1, 2, or 3 of the same ingredients, same base, all in the toppy click or the toppy pump, something like that. But at the end of the month, you might have 50 or 60 different recipes for patient-specific patients. You will have to do a standard product labeling upload for every single one of those. So it required us to start at 8 in the morning till around 3 in the morning every day for 30 days. You have 30 days to do it. And we had to submit, and then it would reject, then submit, and then it would reject. The other issue is, again, as a 503A, you might buy powder from, packaging company, PCCA, Medisco, Letka. I don't want to advertise one over the other, but all of the powders are supposed to be put up into the database with the FDA. But let's say they didn't. They're out of compliance. As a 503A, has anyone in this country gone on and went to the FDA website to make sure that the NDC for a specific powder was registered with the FDA? No. And so when you go to submit that bias test that you're using, and if the NDC that you're using is not been registered with the FDA, it will deny your submission. So now you're out of compliance because the powder company was out of compliance. I think it was originally designed that if you were doing compounding for office use, they wanted to see what you were doing sterile in the last 6 months to look at your risk assessment profile. I would think that probably, I even told them, the FDA, probably 50 to 70% of the first upload when you initially register, if you were 503A, 50 to 70% is not in their database system. And it's totally, they're sitting in the pharmacies waiting for the FDA to come look at it because of the computer issue. And I even asked them, I did a progesterone 200 milligram capsule for a patient 3 months ago. They already took it. It's gone. What does it really matter? Does that really do anything? And so I think some of those changes need to happen. It's just because of that law that was there. I really just think that, and then let's say you do your standard product labeling right when you register. We registered in May. So you go ahead and upload everything in May. Well, then in June, you got to do everything that you did from January to June. Well, do you submit it again? Does that make it look like you made twice as much? And the thing is, yes, you submit again. So they don't tell you these things. So I think those are some of the issues. And when you're dealing with patients, you're dealing with powders, trying to transfer patients out. You're probably have your employees that are, used to patient specific. I think some 503As that want to become a B just think, we'll just do better recall procedures. And, we've done a stability on our sterile product. We've been doing it for 10 years. Oh, really? Well, I just think there's the small finite details get overlooked. I don't think it's arrogance. I don't think it's any of that. I think it's just it's an overconfidence in their product, knowing that they probably don't have anything wrong with it. But to the FDA, they look at it and say, believe in God and everything else must be verified. So they look and say, well, where's your scientific data? And you go, well, here it is. You go, okay, well, that was great. And who did this testing for you? Oh, that laboratory? Oh, well, they're not FDA registered. Have you gone in and looked at these people? This was 4 years ago or 14 years ago. What powder are you using today? Is that the same? Are you using the same vial? And they just naturally will ask you a bunch of these questions. And then when you get the in the middle of that interview, that's when they go, maybe is not really, this is probably not the best advice for you to go down. So I think as a 503B, you take a fresh start. Many times I explain that a 503A is like a fast food, I kind of give the synonym of like Chipotle. You make up all your different ingredients, you put them in the little buffet thing, and people come up, they say what they need, and you make it for that person. You're making it patient specific. Have a good day, and there you go. Everyone knows to put so much cheese on a pizza, someone knows how much chicken to put in a burrito bowl. But when you go for quality, you basically say, what are we going to make? And then you work backwards. So a 503A and a 503B have different mentalities. You would say, well, what are we going to make? We're going to make blank. And so it would be where you'd say, well, we're going to make a cheeseburger with no onions. Okay? Someone comes up and says, I want a cheeseburger with extra onions. Sorry, we don't make that. You don't? No, we don't even have onions in the facility because we're never going to put onions on a hamburger. So you're 100% time you're going to be compliant. You're never going to have onions on it. But with a Chipotle, oh, I'm sorry, we actually gave you onions. It doesn't happen in a quality standpoint. They have so many firewalls that it should never go out. And so I think it's just easier.
Yeah.
I think with a 503B, just to do it it can be done, but there's just a couple more hurdles, but I don't think it's undoable. I mean, absolutely not. So,
yeah, I think
I hope I answered that.
yeah. I think that I was in a class recently and somebody asked something about where do what's a good reference for me to put on my formula worksheets for beyond use dating. And this is just another difference between 503As and 503Bs. So I couldn't help but, just raise my hand, and I am that guy in the class and say, look, if you actually think about this, I think that whole beyond use dating and referencing some kind of journal or trissels or whatever from 30 years ago, that's not going to be the wave of the future. So I would probably not hang your hat on that too much longer. And the person kind of looked at me and like a little puzzled. And I was like, all right, let me break it down for you. So trissels, maybe they were doing something in a lab 30 years ago with some powder, a lot number that you don't have, and it was compounded by not you, and it was also done, like I said, 30 years ago. So how is that study applicable to what you're doing today? And he was like, oh, okay, I kind of see what you're saying. And that therein lies the difference between, the basic mentality of the FDA and your typical 503A compounder. They're kind of resting on the fact that, like, well, I'm putting stuff out. It's never harmed anyone. No harm, no foul. And it's just, we've been doing this for so long and nothing's ever gone wrong. So it's fine. No, like, you have to have scientifically backed data saying why it's okay. It's just a different way of thinking, I guess.
I think the BUD dating 795 and 797, I think, gave a great cliff note for the patient specific to make something up, hand it to them, and let it go out the door. Typically, even if it was something sterile, if you were going to make up like an IV or a TPN or something like that, and you would hang it and be gone within 48 hours or something like that. But when you start making up vials that are going to sit there for 3, 4, and 6 months, I'll be the first to admit, I'll admit it to anybody, and I would gather and say, of all the 503A pharmacies before F503B, what we all did was we said, well, if I can see it, that was my validation. So let's say you make up B12, and you go, okay, we're going to do not cyanocobalamin, we're going to do methylcobalamin. Yeah, that's what we'll do. So we're going to take methyl B12, we're going to make sure our math is right. We'll do our loss on drying. We're going to do our SART conversion. We're even going to take our water and say, oh, we're going to put that in 1,000 mils. The displacement of that powder is not a lot. But in other things, it would, and you would want to account for that. But we're going to do all that, and we're going to throw it in there. Okay, it's in there. Great. And then what people do is they send it off, and they said if it's sterile, green light. The sterility was the end-all, be-all. And that's the problem. If you really look with the way the FDA looks at it is, are we giving just sterile water? No. We're giving something sterile with a B12 in it. That's what it says on the label. So how come we don't do potency testing? I can tell you, I don't know how many people probably got a formula, put it all together, maybe sent out potency, but really did a potency testing multiple times, different time points, 2 months out, 6 months out? No. Everyone always did sterility. And for that fact, people probably did in-house sterility and even endotoxin. And so the thing is it may be sterile. Great. It's sterile 3 months from now. That's awesome. But is the drug even in there? That's the problem with 503As is they're sending stuff out, and can you tell me 100% of the time that the drug's actually in there? And so, I just take it a step further and say, if you don't know, how can you claim it? And I think that was a big startling thing for me, that when I saw all these things, I felt, that is an added expense. It just makes more financial sense for me. I'm going to do all this testing that, I need to do them in bigger batches, and let me get good at doing a couple of things and just do it as a 503B. And so, for every batch that we do, it's endotoxin. It'd be, if it was something sterile, there'd be an endo, sterility, and potency. And sometimes you even do a preservative test. Who even does a USP 51 to make sure that your preservative is even effective? And these are the things that are typically not required or asked of us if we're going to give it to a patient within 10 to 14 days and then it's gone. But things can change when we're talking 6 and 9 months out. I know there's people out there that we used to make Toradol. Toradol doesn't really react well with oxygen. That's why it's purged with nitrogen. That's why you don't see a 100 ml bottle of Toradol. But us compounders, we know the Toradol's in there because we put it in there. Yeah, I know you put it in there. Is it still there? Did the pH change? So, and then we say, well, it never hurt anybody. Well, it didn't. Maybe the Toradol lost potency. Okay. But was that the best thing for the patient? So I just, that's where I caution people is the BUD is not, we put a huge occurrence on sterility. But we also need to look at, if it's sterile, that's great. There's also potency, endotoxin. Those things need to be looked at as well.
Yeah, absolutely. Any other last words of advice for someone, other than not doing it from a transitionary standpoint, but actually doing a 503B startup? Any other piece of advice?
Yeah, there's a lot of people. You might have a ton of recipes or a ton of formulas, you call them, master batch records. We might be doing a ton of things in a facility, and you might want to keep them all. Just realize if you go to do all those, it's very expensive. It's sometimes just really good to start with a clean slate, start slow, master one thing, get it, because it does take, I don't want to get all sentimental, but it's many times the closest thing I can explain is when people talk about in religious details where people say that the veil has been lifted. When you hear to the FDA has jurisdictional when you have drugs that are stored in a contaminated filth area. So we think, well, wow, we go into a room and we see cockroaches and we see bugs and we see all that. Yeah, well, that makes sense. But then it hit me when I was listening to the FDA. And they said, well, do you have a vial sitting on the shelf? Yes. Does that vial have a drug in it? Yes. Well, inside that vial, is it sterile inside that vial? If it's not, is that a contaminated area? Are you storing a drug in a contaminated area? Yes, you are. And that kind of hit me. I said, whew, they are really taking it now to the container, to the package. That's what they're looking at. And so I tell people, don't be scared, but make it to where quality is your core. It's the management, it's the control, and trying to control all of that in the most plausible sense that you can. And just, it is going to be expensive. That's one of the hardest things to stomach. But if you truly believe in it and you believe in yourself, you can do it. It's not unattainable. Big pharma does it every day. You just have to be a little bit unique, and you have to kind of, work within the constraints. But there are times when you want to pull your hair out. I tell people, I think the best thing that helped me was to pull up the inspection sheet that they follow, 7359.006A, if I'm not mistaken. I might be a little bit off on that. And read it. Go through that and read that. Stop for 1 minute being a pharmacist. Stop being a technician. Stop being an owner. Stop being any of that. and just walk into a room, sit down and read it and pretend you are an FDA investigator. Read that. And what would you ask somebody when you were walking into a facility? If you can answer all of that, you're golden.
Nice. Well, cool. Brian, you still on?
Yeah,
There you are.
I've been making notes. I've got like a page and a half of notes on a yellow legal pad because my brain is just all over the board here. It's
I admit, I'm sorry, I go all over the place, which is kind of bad, but
no, I love it. It's that's my brain is never going to be a linear animal, and I understand that. Matter of fact, one of the earlier things that you wrote or that you said that I wrote down is that you like to say that you're type A, but then you're partial type B, so you're really kind of a hybrid personality. I absolutely dig that because I'm the A guy who loves to stand up in front of a crowd of 150 people and talk at a conference. But then on the B side of me, I want to dig knee deep into the process. And then that made me think about a movie that I saw recently while on an airplane. It's called The Founder. I don't know if you've seen that. It's the story of Ray Kroc.
Yeah,
so the story.
Yeah. But the McDonald's thing.
Right. So to me, the story was not about Ray Kroc, or at least my takeaway was not. What I saw and what I felt and what I got excited about was the McDonald's process that the McDonald brothers put together.
He had it down to a science.
Absolutely, because you
remember how they were like everyone gets 2 pickles, and and they move stuff around. I mean, they had, I saw it and it was like, dang man, they're taking on like a GMP. They didn't even know what they were doing.
Yeah, when they went out to that tennis court or basketball court with the chalk, and they were chalking it off, and then they erased it and they drew it again because guys were bumping into each other, and they built the process. And then you notice the one brother, he would go over to the fryer, and he was concerned about the most accurate temperature with the most accurate time. You know, was it 390 degrees for 4.5 minutes? And then he was always scrutinizing that end product. And for me, I was more excited about that. So not so much about the success of Ray Kroc, but it was the process. And so I love.
Yeah, the McDonald brothers, when I watched that, I was like, I had a new profound, and I think that's one of the things that Chick-fil-A does well. Chick-fil-A is very big here. Down the street from me is the grandfather, the founder, Leslie, his granddaughter owns the one down here. You go in there, the fries are the same every freaking time. But they make that if you own the store, you work there 40 hours a week. You don't own 30 Chick-fil-A's. You could be a store owner. You could be a guy working on the fries, move up, and you can open a franchise. If you work with, you apply, and you can open a Chick-fil-A for $10,000. It's the McDonald's mentality. And so that's when you go, their food is always, guys know what I'm talking about. You go in, and it's like, dude, the fries suck this time. Like, come on. I sit there and go, do you have any quality? I got a picture that I've been wanting to send people. I was in Walmart, and I was walking in, and I was like, oh, my gosh. And I don't do this. I don't take pictures of people. But I was walking back out. She was still sitting at the bus stop right outside of a Walmart. The girls in full scrubs, booties, hairnet, everything. And I was like, I got to take a picture and say, where did the bubble gum come from? How many times? I bet you she probably don't even freaking change and walk right back into some OR of a hospital down the street. Mm-hmm. Like, who cares? What was the purpose of that? And
make quality. One thing that I wrote that you said, and I've got it in quotations, make quality as your core. Because you essentially, from beginning to the end, you wrapped your entire conversation 360 degrees. When you were talking about the potency testing, the sterility, endotoxin, and you bring it all together as a process, and you wrapped it all the way back to quality, which is exactly what you were talking about in the very beginning as it related to French fries. So for me, that was just a complete, like I said, I got a page and a half on a yellow legal pad just of just things I want to go back and revisit. I could see this conversation could go on and on and on. We could get 3 podcasts out of this. You
literally have your own internal FDA inside your facility. And so I've got, like Director of Quality Assurance and Regulatory Affairs, and then I have a compliance officer. So the quality assurance person says, how can you assure this is quality today? You guys didn't do this, this, and this. Your compliance officer makes sure that they go and do the SOPs. Quality assurance says, let me see the SOPs. Let me open up the drawer. Do you have an old SOP that you're using? Why are you using an old SOP? Why do you have whiteout in the building? What are you doing over here? I don't think so. And so they're constantly kicking the tires, looking for the bugs, inside a facility of saying, hey guys, you're slacking over here. Or they might come in and just watch you and go, hey man, your SOP was awesome 3 months ago, but something happened here. You guys have now, what'd you get, like a new little part or something? So now you're making this thing totally different. Well, is that going to affect it down the line? Well, what matter of fact, it does. And we just wing it. No, we can't wing it. So we're going to have to make it, we have to make an adjustment. So it's like your own FDA person.
Thanks so much for listening. We actually have enough from Bill's conversation for even a third episode, so maybe we'll hear more from Bill. A couple of announcements. Brian and I will be in Florida at the ACA conference February 28th through March 3rd, so please stop by and say hello. We're going to be recording a couple episodes. In the next couple of weeks, we're going to be speaking with Erica Fallon of Fallon's Wellness Pharmacy, where I'm from in upstate New York. Erica not only runs basically the only compounding pharmacy where I'm from, but she's also heavily involved in IACP as a board member and sits on a couple of their committees specifically dealing with regulatory and the legislative initiatives the organization undertakes. It's going to be a wicked conversation, so hope you can join us. But coming up next week, Brian and I will be having a grudge match of sorts. We'll be debating a topic or two I think that people don't have a great consensus on or grasp of, and talk through some of those issues. One of those topics being gowning and another cleaning and disinfection. We'll also have a forum discussion to see what your thoughts are, so I really hope you tune in and participate in that. Until then, keep raising the bar.